Assalamu alaikum. History station, palpitation. So the scenario may be 15 years old teenage. She presents to AE with heart raising few weeks ago. Missed her cardio appointment and now come to Europedium. Okay. So first of all, the differential diagnosis. The palpitation differential diagnosis: cardiac cause, non-cardiac cause. Non-cardiac cause, there is lifestyle change such as taking caffeinated drinks, taking alcohol, smoking, and recreational drugs. And there may be a history of any anxiety, fever, thyrotoxicosis, anemia, diabetes, hypoglycemia, recent dietary change, increased exercise, and medication, beta agonist, and also nasal decongestant and diet pill. And cardiac cause, arrhythmia, supraventricular tachycardia, ventricular tachycardia, heart disease such as cardiomyopathy, mitral valve prolapse, aortic stenosis, and after surgery. So the history, onset, course, and duration, anything make it better, and how it relieve, and is it, then we will ask for any red flags present or not, such as is it associated with any chest pain, do you faint following this, and then what do you do for this, do you under any kind of tube, and then the constitutional symptoms: fever, weight loss, sleep, daily activity, and then systemic review. Systemic review in the CNS: is there any convulsion, fainting attack, dizziness, cardiovascular system, breathing difficulty, and do you ever measure your blood pressure, and is there do you notice any blue coloration around the face, and then cough, any kind of cough, and do you taking any medication for this cough, and then part abdomen, any tummy pain, any throw up, and urinary system symptoms from diabetes: increased thirst, increased pee, and endocrine system, any neck swelling, any concern regarding his eye change, any what's about do you notice any kind of pallor, and then after there is past medical illness, that any kind of surgery, any then prenatal history, and then for growth, dietary history is very important here, and developmental history, and any history of medication she is recently taking or not, and then family history. And after this we can come the diagnosis: is it the cardiac cause or non-cardiac cause. Now how will you manage this case? For management, I will examine the child if it is acute airway, breathing, circulation, vital sign, blood pressure, SpO2, and will run investigation 12 lead ECG, especially looking for atrioventricular atropic heart block, delta wave, long QT interval ventricular hypertrophy, and to rule out other case, full blood count, thyroid function test, dehydration, and if needed discuss 24 to 48 hours Holter monitoring as outpatient department with senior. And management: if it is non-cardiac, history suggestive of non-cardiac, negative family history, and normal CVS examination, normal 12 lead ECG, so no specialist input is necessary. Arrange routine general pediatric OPD department and advise to maintain symptoms diary. But if it is cardiac, that is, it is associated with exercise syncope or pre-syncope, known case of congenital heart disease, positive family history, abnormal examination, abnormal 12 lead ECG, discuss with local pediatrician who is expertise in cardiology, refer to cardiology OPD, and arrange ambulatory ECG. So if it's a case of supraventricular tachycardia, how will you manage? In supraventricular tachycardia, regular narrow complex tachycardia rate is 200 plus minus 40. P wave usually absent. And then other investigation for SVT is selected acid-base balance and electrolytes, ionized calcium, echocardiography to assess the structural abnormality and cardiac function. And treatment, first of all, airway, breathing and circulation, and continuous cardiac monitoring, and vagal distribution, driving maneuver. This is the use of ice bag over the forehead and nasal breath for 30 seconds, or wrap infant with a towel and immerse the face in ice water for 5 seconds. Valsalva maneuver, asking the if the child, for older child, ask the child blowing into 50 ml syringe for 15 seconds while lying down. But not recommended are ocular pressure because risks of injury, carotid massage because it less effective, gag reflex by NG tube. These are not recommended. IV adenosine. Adenosine we have to give antecubital vein and very rapidly, and this three-way tap with the one syringe from adenosine and another one syringe from sodium chloride 0.9% with flush. So how the protocol is, if the child is shock is not. If the child is shock is not present, so vagal maneuver. But if the shock is present, vagal maneuver as quick as possible, and establish IV channel. And if IV channel is established, by this time we can give adenosine 100 microgram per 2 minutes, and after 2 minutes 200, and after 2 minutes 300. And but if establishing if IV access quicker than obtaining defibrillator, we can give the synchronous DC shock 1 joule per kg and then 2 joule per kg, and consider immunotherapy and treatment of the underlying cause, and we will keep the child under follow-up. Thank you.